Good afternoon. Sorry I can't be there with you today. I'm very much looking forward to my trip to Melbourne, but here I am in New York City talking to you about the pandemic and the effect of COVID-19 on peer review. I've got 20 minutes, so I'm going to be rather quick and pithy. Apologize for that, but feel free. Hopefully we'll have a chance to answer some questions if you have any. And you can always contact me at the information shown on this slide. So thank you to the organizers for the invitation, and thank you to the chair, Professor Scott, for organizing this panel. So my conflicts are shown here. The main ones of interest are that I am an editor-in-chief of the British Journal of Anesthesia, and on the advisory board to Elsevier, both of which have to do with publishing. But these views are mine as editor-in-chief of the British Journal of Anesthesia. Brief outline, what I'm going to cover. I'm going to talk first about the pandemic in New York and the impact that had, I think, as an example of how, of the environment we were all living through and how that impacted both publishing and research during that time while we were taking care of an onslaught of incredibly ill patients. I'll then turn to the impact of the COVID-19 pandemic on the BJA itself, and then finish up with a couple of comments on the impact, the lasting impact of this pandemic on scientific publishing. So I'm going to first start out with a very personal and local description of what it was like in New York. And I know everyone has their own version of this around the world now. But we started out in March, so just over a year ago. New York City became the epicenter of the COVID-19 pandemic in the US. The first patient arrived in New York City on March 7th. We had in the first ICU patient arrived in our hospital on March 7th. We had 12 patients at that time that we knew about in New York. Now you can see the rapid increase on the top in the number of cases, though. It came on very quickly, and that's what caught everyone off guard. In retrospect, it's a bit surprising that we didn't take this more seriously sooner, but starting with that first case, we restricted travel right away. WHO declared the pandemic on March 11th, and we canceled elective surgery in our hospital by the 16th. So we acted swiftly to respond to the onslaught of cases. The department and the hospital focused on operating room safety, and we were challenged by a number of issues. One was lack of personal protective equipment, relatively. So we had very limited supplies. That was initially quite a problem. We had limited testing for SARS-CoV-2, which was also a problem. We immediately stood up a task force to develop protocols for conserving, donning, and doffing PPE using simulation, and we prepared our operating rooms for dealing with COVID-19 patients. Many of our staff who weren't involved in ICU were redeployed to various parts of the hospital and the medical system. And we formed teams to deal with the ICU, to deal with intubations on the floor in the ICU, in the emergency department, to put in lines on critically ill patients. And our hospital quickly became a COVID hospital. And that's been played out around the world many times and continues, sadly, to this day. This is a collage of photographs of healthcare workers who have died in Mexico as a result of COVID-19 that we published on the cover of our journal, the British Journal of Anesthesia, in December. So we did a lot of team training. I mentioned we had an OR airway team, we had an ICU team, proning team, lines teams. We got together and trained everybody and brought them up to speed in these specialized areas. One of the limiting resources we had was ventilators and ICU beds. We developed a phased plan to expand the ICUs. first into our step-down ICUs and then into our PACUs and operating rooms. And you can see in this slide the overnight construction of additional ICUs in our PACU, which was quite impressive. We were able to add another 90 ICU beds. We converted our operating rooms to ICUs. You can see the plan at the top where the central core became the sort of clean area, and each operating room held 2 patients. The picture there shows 3. We did have the capacity to go to 3. It just was quite crowded. That was life-saving, I think, at the peak of the pandemic for us. There were a lot of downsides in addition to the death and disease. The operation of the hospital and the medical school completely shut down. All meetings were canceled, grand rounds was canceled. But we replaced that with Zoom. And here we are, still Zooming. We were doing 14-hour days, 7 days a week for about 3 months, dealing with all the challenges of the pandemic. We had to have regular meetings with our staff, faculty, residents to keep them up to date, to discuss whatever the crisis du jour was. And our program director for our residents met with them daily. They were having a very tough time being on the front lines. A lot of medical care shifted to telemedicine, which we still have, in fact. The challenges met by our residents were summarized in this nice correspondence piece in the British Journal, where they describe some of the changes they did to maintain some level of training during this crisis, where they spent average 3 extra months doing critical care as part of their residency. Some of them were sent to outlying hospitals that they had never seen before. Everyone was incredibly happy when they were able to come back and actually restart our operating room schedules. So the increased demand in the ICUs required 12-hour shifts, usually 6 days a week for most people. We canceled 90% of our operating room cases, everything but emergencies and urgent cases. And we wouldn't have made it without ICU staffing coming from our colleagues across the country, including UCSF in Utah, shown here, nurses from across the country. And we had an outpouring of support and philanthropy to support our meals and bus routes and childcare for all the people that were working on the front lines. And there was a public support too at the 7 p.m. clap, which is shown in this recording outside my window, which was actually something I walked home to every day for a while, but I have to say, I don't miss it. So this is what our peak looked like in March. I think our peak, the actual peak was almost exactly a year from today, which I'm recording this on April 9th. It did take a while to come back down. But you can see on the overlays curves here that once the cases went down, we had a relative quiet phase, but then we had a second peak in New York anyway, which were just it's plateaued for a while, and we're just starting to eke down ever so slowly. I mentioned that the surge in ICU patients really affected elective surgical cases. That wasn't just in New York, but as the pandemic spread, about 70% reduction across the country in the March-April area. In New York, we had, and the rest of the country here as well, we had a secondary pandemic. That was the burnout, the exhaustion, the PTSD we're still living with, really, from the pandemic. I think many people when we watched what was happening in the rest of the country and the rest of the world, we could see what we had just gone through, and it was very traumatic just watching. We're now dealing with pandemic fatigue, a massive financial crisis here in the hospital, and at the same time this was happening, or shortly after, we had civil unrest as a result of the George Floyd murder, which is now undergoing trial. And you can see here, this is also out from my window, a protest march against the New York Police Department during just after the peak of the pandemic last year. The impact on our team has been immense. No travel, quarantine, loss of income, promotion issues, home issues with schooling, spouses losing their jobs, the residents' impact on their education. Here's a collage of them, our 2020 graduating class. They were real troopers. We wouldn't have gotten through the peak without them. So now let me turn to the main topic here, which is using that as a background of sort of what was happening while the journal was still operating. I'm going to discuss how we managed the COVID-19 pandemic. So the impact on the British Journal was large. Here are covers for the last year. You can see for the first cover dealing with COVID-19 was in May, and that's shown here on the right, on the upper fifth cover from the left. I'm sorry. Then the next 2 months later, we had our intubating box, and then another healthcare worker, and then finally the collage in December. There was a surge in submissions to the journal. This was common to most medical journals. You can see the blue was our submissions from 2019, and the red is from 2020. The peak in May there, almost double. And the lines on the bottom show the cumulative number of submissions year on year, and you can see that 2020 was a real outlier. It did start to come back down. Most of the increase, but not all, was due to COVID-19 related papers. And you can see that here where we have 2019 versus 2020. We went from about 1,700 submissions to 2,500 with about 500 COVID papers in 2020. Despite this surge in papers, we maintained our historical rate of rejection. So we reject about 80% of our papers, 75% to 80%. And this was very similar to prior years. This took a huge effort from our editorial team and our peer reviewers to review all these papers. So most of the increase, interestingly, was in correspondence. And you can see this goes from, 17% to 25% of our submissions as correspondence from 2019 on the top to 2020, the purple part of the donut. This surge in correspondence, I think, was to fill the void left in original research and our thirst for knowledge about this disease. And we got many letters, many editorials. Here's a page of a table of contents from September where we had 33 letters just on COVID related topics. We peer reviewed all of these, which did require quite a bit of work. And despite this volume, we were able to decrease our time to first decision from 14 to 9 days. We created a special section, COVID-19 and the anesthetist, a special series. We published some really early work, including this outbreak of a new coronavirus, what anesthetists should know, which was published in May and has already received 180 citations. So finally, let me turn to the impact of the pandemic on scientific publishing in general. So the sort of major impact was the massive increase in the use of preprints for scientific and medical communication. So preprints are peer-reviewed manuscripts that are loaded to preprint servers that are publicly accessible, that are able to be commented on by reviewers, and provide really open publication. So there's minimal to no fees, and anyone can see these papers. Now, this is not a new concept, preprints, but I think in the face of a pandemic, the preprints were seen as a rapid way to get information available, and also to allow people to comment on the works. And you can see here on the upper right, well, on the left, let's look at that first. You can see that there was an increase in the number of papers uploaded to medRxiv, which is one of the major preprint servers. And in the orange, you see the number that are COVID related, and that was the majority of papers coming in. And that's also graphed in the upper right. In the lower right, you can see that the rapid review process of papers that were submitted to medical journals increased for COVID-19 papers. So there was a focus on peer review and fast tracking of papers that had to do with COVID-19. And that happened with us as well. So all of our COVID-19 related papers that were accepted were fast tracked for production and were published freely available to the public, and still are. So what are the consequences of this shift to preprints? Well, the fact that they haven't been peer-reviewed does increase the risk that there will be incorrect information, even potentially fraudulent information published in preprints. And the idea of preprints is that it's an opportunity for readers to comment on the work and for the authors to revise their work accordingly before they submit it to a traditional journal for peer review. Now, that has been happening. A number of the papers that have been manuscripts that are posted on preprint servers have been submitted and published, but the percentage is actually surprisingly low. And it's not clear whether that's because the backlog in peer review, which, as I mentioned, has been really challenged by this, or whether some of the work posted is low enough quality that it will never even be submitted to a traditional journal, and whether that's because of feedback from readers or not, we don't know. An interesting observation is the origin of the manuscript submitted to preprint servers. And also, it's similar for traditional journal articles. China led the way, not surprisingly, followed by US, UK, and Italy. And these are all hotspots for COVID-19. And you can see that on this color map on the bottom. So most journals will accept preprints, accept manuscripts that have been previously posted on preprint servers, and the British Journal of Anesthesia is one of those journals, and we published that in an recent editorial. So we embrace the concept of the preprint for those who want to use it. There are the risk I mentioned of having materials available that are not peer-reviewed, but we will take those manuscripts and peer-review them. And I think the concept of pre-publication is here to stay. It's not without danger, as I mentioned, there have been a number of retracted papers related to SARS-CoV-2 and COVID-19, as Andrea Cortegiani addressed in this correspondence that was published early in the year. And this was based on an analysis of from Retraction Watch, the website, done in November. And at that time, he found that there were 45 retracted papers. About 30% of them were preprints, but so the majority were not preprints, but there are some, even preprints, that are retracted based on mostly on feedback from readers. So I think this system is working and has the potential to be a real asset. And a lot of the really critical findings related to SARS-CoV-2 developing a vaccine to the spike protein were based on findings that were originally published on preprint servers. So let me wrap up in the final minute. The COVID-19 pandemic really had unprecedented effects on the medical literature. I think those are here to stay. The doubling of submissions that we saw in 2020 occurred in a way that I think our editors and our reviewers were able to step up and maintain our selective review and timely peer review process. Whether we could do it again for another wave like that, I don't know. I think we all feel that we're not sure that our hospital could survive another wave like that. We're very close to the breaking point. The increased role of preprints in medical and scientific communication, I think, is also here to stay. And this pandemic has had a lasting influence on science, medicine, and society, as well as publishing. So I'll stop there. Thank you. I look forward to addressing any questions as you stare into the sun on Manhattan Henge Day. Thank you very much.